All right, good morning. It is February 2nd, Groundhog Day, and this is Senate Health and Welfare. So we haven't seen our shadows, which is a good thing. So maybe spring will be early. We're gonna move on today to S98 and then S173, and then we'll finish up and have a process discussion later on. Okay, so Susan Barrett is here from the Green Mountain Care Board. Susan, why don't you introduce yourself for the record and give us your thoughts on S98?
And Susan.
And you're going to join us. Okay,
Sorry.
Both of you introduce yourselves for the record. That'd be awesome. You
Great.
did tell me she was here, so here she is.
Yes, thank you, Madam Chair, and thank you, committee members of the Senate Health and Welfare Committee, for having us in today. I'm Susan Barrett. I'm the Executive Director of the Green Mountain Care Board, and I'll have Julia introduce herself.
Yeah, good morning. My name is Julia Bowles. I'm a health policy advisor at the board.
Terrific. So are you both going to contribute and then, okay.
Yes, so I am,
right ahead.
Yes, so obviously I'm remote, getting over a bout of COVID. Luckily, got my vaccines on board and it was really quick, but you don't want me in your room today. So I'm here, but Julia is there and we are going to do a bit of a tag team here. We have a few slides. And the purpose today is to talk about S98 and then run through, these 5 or 6 slides and then obviously just answer any of your questions. We do have some recommendations and we'll just start off. So I think the most important thing to say up front is that the Green Mountain Care Board supports S98. We know that pharmaceuticals are not transparent, the supply chain is not transparent, the costs are not transparent, and we see every day in the work we do at the board the impact of the high cost of pharmaceuticals on healthcare costs. So we do support S98 with a strong caveat and request that we are staffed appropriately and we have the resources to accomplish this very important task that you put forward in S98. So as I said, we're going to run through some slides. We've done some initial research and talked to some other states, and we'll share what we've learned with you today, but we really do want to continue this conversation. I want to have more conversations with the GMCB legal team and our data team. And I'd love to talk to some of your experts that we listened to the other day. I guess that was last week, and continue to learn how we accomplish this.
Let me ask you, Susan, sorry,
Yeah.
not to stop the flow, but
that's fine. Please.
Certainly, if you need access to the experts that we talked with the other day.
Yeah, that would be great. I know I've worked with Jane. Is it Jane Howarth? I worked with her when she actually, I was on the pharmaceutical cost NASHP group years ago. Julia is now representing the Green Mountain Care Board on that group. So we do know them. So we may just reach out to them if that's okay with you, Madam Chair.
Okay, so you're all set with that. I was going to say, we're happy to make connections if you need that.
That would be great. Yes, that would be great. Okay. Wonderful. So, okay, so we have a few slides. Julia, yeah, the next slide. So you all know who we are, but we always like to stop and just take a moment and remind everyone about who the board is. There might be people watching who don't know who the board is. So we were established in 2011 as part of Act 48. We're 5 board members, and I'm pictured there as well. I'm the executive director, as I mentioned. They have 6-year staggered terms, and most importantly, the board is an independent board. It is not part of the administration. It is apolitical, and that really brings a lot of value in the work that we do and our regulatory decisions and elsewhere in the work that we do. And we are, in some of our regulatory structures, we have a quasi-judicial role. This is our mission. It's the triple aim. You know this, but I'll just say it out loud again. because these three things guide the work we do every day, at least for me. Every day I get up and I say, okay, how are the decisions we're making today going to impact access, affordability, and quality of healthcare for Vermonters? And we do this in different areas of our work. We, as I mentioned, regulate major areas of Vermont's healthcare system. We have data and we provide an unbiased source of information and analysis to different agencies in the state. Your own joint fiscal office accesses our data. And we obviously use that data in our regulatory work and other work. And then I think another important role that we play is we monitor and we evaluate throughout the system, and any payment or payment reform decisions that are made in the state, the board uses that lens of access, affordability, and quality as we look at those different reform efforts and we evaluate them. Go to the next slide. And then this is an important slide. This is what I call our bubble slide. So in the green circle, these are all the entities that the board directly regulates. And on the outside in the blue are the parts of the system that the board does not directly regulate. For the purposes of today's discussion, you can see pharmaceuticals is not in either category here. It certainly isn't in our green bubble. But on the next slide, I can show you where we do get some information on pharmaceuticals. The important point here on this slide is we do have direct regulation on hospitals, ACOs, certificate of need. We're doing the hospital sustainability work, and we have that direct impact on those entities. But we know whenever we make a regulatory or other decision that we're keeping in mind those other entities that we don't directly regulate, such as FQHCs, primary care, independent primary care, DAs, SSAs, other payers that we don't regulate. So it's an important concept, and it's really what we call our system-wide view. And I think particularly in recent years, we've really established that broader view of the system, and it's been beneficial. Next slide. Okay, so this is the current data that we do receive on prescription drugs and our view of them. It's pretty limited. So we have all payer claims database. It's called VCures. And many states across the country have these. This is where de-identified, so we don't have any identifiable information. And in actuality, the board does not have any of this data in its hand. We use an outside data warehouser to collect this data, and it is de-identified. And this is all payer claims. So it's a great source. I talked about some of the unbiased data that we provide to other agencies and to your JFO. This is a really useful resource to study health policy, regulation, impacts of different decisions on the system. The one important point as it relates to S98 is that we don't collect all pharmacy data. We have some pharmacy data, and we have specific numbers that we can send to you. It's very technical, but it's just important to know that we don't have all pharmacy data. We also receive reporting since Act 193 of 2018 was passed. This is a report, and there's a link in this slide, that for any major medical health insurer with more than 1,000 lives, they have to report the overall impact of prescription drugs on their premiums. It's information they're sharing to us. It's just a report out, and it's something. It's something that the legislature has done to gain transparency into the system. And then, yes, did someone have a question? Okay. And then I said this earlier, in all of our regulatory processes, particularly in rate review and hospital budgets, we see the impact of prescription drugs and the high cost of prescription drugs. So we want to be part of the solution, properly resourced, of course, but we know that it's just a massive issue, and we're very eager to work with you to see how we can help resolve this situation. And I think I'll stop there and turn it over to Julia unless there are any questions. Or should we hold those till the end, Madam Chair?
No, let's go right ahead.
I think
Sure.
Julia's next. She's got some data. She's been busy doing some research. So go for it, Julia.
Yeah, so, and I will say, I know this is hard to read, so I know the slides are posted on the website, and there's a link in the bottom left that goes to the chart that I screenshotted here, so I just want to start with that since I don't want anyone's eyes to be strange, but my, well, to back up, I listened to the testimony. I was in the room last week when you all had to walk through the bill and we heard from some of the experts. Since then, I've been reaching out to some of the other states that have these prescription drug boards and trying to connect with just to get more information, because my understanding is that each of these boards are very different from each other. And so we want to figure out how to do it the best way for Vermont and the system that we already have. So this chart is a summary from NASHB's website of the existing prescription drug affordability boards. As you can see, and again, definitely go to the website to see better, but they're all relatively new. Maryland was the first state to pass one in 2019. And since then, these other states have tagged along. They're all very different, is my understanding. Even the ones that have similar authorities, there's differences within their statutory language and the types of criteria that they are tasked with looking at. Some of that has to do also with the unique structures that states already have set up, depending on where they are in their process of working on prescription drugs. But I highlighted 4 states here, which is Colorado, Maryland, Minnesota, and Washington, because those are the 4 states that have upper payment limit authority, which is the same authority that's currently in S98. Some of the other states, if you look at the far right column, have different scope populations that they impact. So our neighbors in New York and Massachusetts have prescription drug boards focused on the Medicaid populations. And then New Hampshire and Maine are looking at public plan enrollees. So there's a lot of different pieces of this puzzle. My understanding is, like I said, they're new. So there's a lot of sort of learning that's happened even since Maryland has first passed their statute. So I think I'm definitely not an expert on the ins and outs of these many different states, but at a high level, my understanding is there's differences. And so, like Susan said, we've been trying to learn about them, but we would love to keep talking about, checking what some of the other states have done, talking with them. I didn't have a chance to get on the phone with folks this week just because the timeline was short in other states, but like learning like what is working for them, what do they maybe wish they had set up slightly differently. All of that. So that's just kind of the lay of the land so far, like 2019 forward. So I wanted to kind of walk through the contemplated process of what a prescription drug board would do for its affordability review. This is a picture from Colorado's website. I've linked it in the bottom left corner, and I thought they had this triangle chart kind of walks through the process that's outlined in the bill. And I've tried to make notes that also reference S98 as I talk through this. So the first step of these drug boards, or the ones I showed and what's in S98, is to look at sort of the world of drugs and determine which ones are eligible for an affordability review. In S98, that's on page 3, it goes through sort of affordability review, the scope, what types of drugs, what the dollar thresholds are, all of that. So that's starting with the big world of what drugs could be reviewed by these boards. From there, there's different ways and I think levels of specificity that statutes have about how to prioritize within that, but I think there's also some leeway for boards to prioritize what drugs they want to look at. The experts last week, I know we're talking about, you could look at a high cost drug that not many people are using, or you could look at a slightly less costly drug that so many people are using. So there's sort of choices in there. And Colorado, this chart just outlines Colorado's perspective on that.
Question for you. So you haven't yet chatted with folks in other states?
No, I talked to the executive director in Washington, but I didn't have a chance to hear back from any of the other ones yet.
Okay,
so
thank you. Keep going.
But I'm hoping to, because I think it's helpful to hear what they think. So from there, so you start with the world of all drugs, and that's really where the data comes in. The states I listed on the previous slide have all payer claims databases like Vermont, where you can look at data about, what is spent on drugs, but this bill also gives authority to collect other types of data because with rebates and that whole system, and again, I'm not an expert on that. Hopefully you'll hear from other people, but that not all of that is always captured in claims data to the level of specificity that you might want for some of these types of questions to sort of uncover the supply chain sort of changing of hands of all the payments. But anyway, so you look at all the drugs, then you prioritize, and that is the selection criteria, which is on page 5 of S98. And then from there, the board can conduct an affordability review. And so for S98, that's on page, again, on page 5. And there's sort of a description onto page 6 of S98 of what that would look like. And then once the board does an affordability review, if they determine that a drug is unaffordable, they can set an upper payment limit. And for S98, that's on page 8. So that's sort of the flow, is like starting with the world of drugs and narrowing it down to looking at particular drugs that are causing affordability challenges, and then from there having the ability to set an upper payment limit. I mentioned that states are very early in these processes. Colorado is the first state to start doing this affordability review, which is the orange conduct part of this triangle. They've got 5 drugs on their website that they like prioritize to review. They've completed 1 review and they found that the drug is not causing it's not unaffordable to Colorado consumers. But they have more that they're planning to do. So I just want to flag that that's the only affordability review that's been done by any of these boards to date.
Interesting.
Slow process.
I could ask one question. So,
Yeah,
so where in the process are they determining that appropriate value of the drug?
Yeah, I am
That's
not an
the whole
expert,
point.
but there are hundreds of pages of documents on their website. I started to look through the report and was like,
Not time yet.
There's not time yet, and I'm definitely not an expert on that particular area. I think the different statutes have different levels of information on like specifying how you define affordability, and I think that's a question we want to.
No, I get it that they determine it unaffordable or affordable, but in the end, aren't they trying to set a cap, trying to set a ceiling for the price? And how is that,
Yeah,
that
that's
process
not, yeah,
is
that's
moving?
not on this chart, if that's what you mean. The next
Yeah.
step is if it was found to be unaffordable, then
Right.
what's contemplated as in S98, the next step would be to set an upper payment limit.
Yeah, I get that, but how?
We don't know yet.
Okay, that's fair.
Yeah, I think it's that I mean, do you mean like, what's the authority for that, or?
Oh, yeah, what's the
how do you pick
authority? How do you peg it?
Yeah,
You know, that's where it really matters.
right, yeah.
And what are the current prices now? I mean, if it's still now affordable, then don't do anything, but then there's also the question of how many doses and how many people, I see it going.
Yeah, and I think that's really gonna get into the expertise question, you know, like this is where these boards have staff who have expertise in the pharmaceutical supply chain and pharmacists related to the dosing.
And also the historical development of the pricing. You know, you could have seen something that was very cost effective 5 years ago, and then all of a sudden it ballooned the way we did with the inhaler.
Thought you were taking a picture.
Yeah, no, I wasn't using the inhaler.
So
Senator Brewer.
we're already hearing from advocates who are concerned about this bill or possibly even opposed to this bill because they're worried about certain diseases and certain
Yeah,
pharmaceuticals.
we'll take testimony on that.
So is it fair to say it's premature for folks to be getting really worried about that just because of what we're talking about right now?
I think so. You know, I think one of the questions that we asked Dr. Sokol last week was, what about the high price, infrequently used drugs for, Parkinson's or other, esoteric, not esoteric, but less predominant diseases.
Mhm.
And she seemed to indicate in her testimony that that was something that can be avoided. We're not gonna be picking apart what's needed for people in really difficult situations. So, yeah. Process, this is a process. big process.
Well, and I would think that also there's the potential to make those very needed drugs cheaper for people. I mean, isn't that part of
Yeah,
the, you know,
but
that's part of the
that's the
point,
benefit.
like,
That's the goal.
that's the
Or
goal, like,
affordable.
and so if you have a rare disease that
Yeah,
has a really expensive drug, then,
yeah, but the concern is if you lower that cost, will the pharmaceutical industry hold the drug
oh, stop.
away?
Stop production or
Yeah.
slow down.
Well, we could, I mean, there could be
That would be a problem.
safeguards to put in there so that that can't be done.
We'll talk, yeah, and that's something we probably can, yeah, we'll have to talk about. I don't think anyone would be that, have that lack of understanding about need for patients. I can't imagine a pharmaceutical company would withhold an
Mhm.
important medication for people who need it. Why don't you go ahead, Julie?
Was that ironic or?
That was sarcasm from the chair.
Was that sarcasm?
It's Friday.
And I do want to say on the slides, I'll hand back to Susan in a second, questions like that or something where we just want to do more research, because my understanding is that other states have started contemplating those questions, like what safeguards can you put in place for, if a manufacturer were to not want to keep offering a drug because of actions of the board, for example. So
Right,
I think that's an area that, would be good to do more research on and see what other states have done. Yeah, so this is my last slide before I hand it back to Susan, but all of this information again is from that NASHP website I linked. I copied the 4 states I was talking about into a table. So this is all just copied from NASHP's website, but I wanted us to be able to read it. And be able to enlarge the font. But this is just a summary of the resources that have been put towards these boards in other states. And the other thing I want to say that's different from the Green Mountain Care Board is that these prescription drug affordability boards in other states, that's their sole function. They might be housed within other departments. Minnesota, for example, it only lists 1 FTE, but my understanding is they have staff, like it says here, from the Commissioner of Health and the Attorney General's office, so it's not just truly one person doing the work to support the board. And then these boards also have board members where doing these reviews and this work is their sole work. So I just wanted to have that here as a reference. And Susan, I think I'm handing it back to you for the next slide, but can stay here if there's anything you wanted to say here as well before I flip along.
No, I think the next slide will actually talk about the specialized skills we would likely need for this. So I think we can move on. Thank you, Julia. So again, I just want to say we do need some more time to do more research, as Julia has been doing, and I want to work with our legal team, etc. So I think this is just the start of the conversation, and I'm looking forward to those discussions. So our Vermont specific considerations include, first, that we would recommend you add to the language the addition of the healthcare advocate in this process, and in a similar way that they are written into our statute for things like rate review and hospital budgets, ACO oversight, etc. I think Julia mentioned this. If not, I'll just say it again. We really want to look at how this would fit into the existing work of the board. And I'm literally talking about the schedules of the board members and where we would put this in. And I think we can work that out, but we want to be aware of where this would fit in. We linked our regulatory alignment papers if you want to do some weekend reading and learn more about our regulatory work. Those papers are really they're a great resource. And then, as I mentioned, do want to talk about to our legal team in how the duties of this work fit into the existing duties of the board. And then Julia alluded to this as well, and the comment about if drug companies would make a decision based on our decision, not, for an upper payment limit to remove, like to not sell the drug in Vermont to the patients who desperately could need that drug. We want to make sure that we look at other states' language to make sure that this bill is stronger in that area especially. And then there's some other language that we may want to tap into from other states who've been successful. And then the last thing, I think today there'll be an announcement, if it hasn't gone out already, from the White House. They're starting to negotiate on the Medicare, those 10 drugs that the CMS will be negotiating with pharmaceutical companies on price for. So we want to see where this work fits into those Medicare drugs and the selection that the federal government has made. And I think that's it for us. I think the last slide could, yes, again, your staffing and funding. And thank you very much for having us in today.
No, this is great. I know it seems to me that there's kind of a, I've written down a bunch of stuff going through, but looking at what other states have done is a good beginning. And then, but looking at Medicare in particular, because we could maybe just piggyback on what Medicare is doing at a beginning level, maybe less intensive in terms of staffing and funding needs. However, it would be important for us to understand each step requires something. And the more robust the board is, I'm thinking the Prescription Drug Advisory Board, the more robust the work is by the board, the more staff you need and the more funding you need. But I suppose we could spend about 2 more months on the bill and get it all in there, but it would be helpful for you to provide us. You've got some great suggestions in there around HCA, healthcare advocate, beginning with Medicare, looking at whether other states are doing. So I'm thinking that, and the other piece that we haven't really talked about is how the data is accessed, and
Right.
that's a big deal. So it would be helpful for us, for you to give us some bullet points on how to improve the bill going forward from your perspective. I mean, you started doing that already.
Yeah, definitely.
great.
It's just
I
a
really
more time
appreciate it.
element. And the
It's a lot of
data
work.
question too is one that I hope to ask other states, because the statute looks similar to what's in this bill, but it lists a lot of types of data. So
Yeah.
in practice, we want to understand what
Sure.
they're using.
Well, we can learn from other states. We may be able to pick the drugs off the tree, but they have to be relevant to the patients we have in Vermont. So you've got all that stuff there. Questions?
Just a quick comment. Since you guys are a little closer to this issue than we are so far, have you seen any effort from the Vermont federal delegation or in the U.S. Senate or U.S. Congress regarding the same issue?
I would say with that Medicare work, the negotiations with Medicare, not specifically with drug advisory boards, but I know Senator Welch has been working on prescription drugs for years and trying to get to this point where we can actually, CMS can actually negotiate directly with the companies. I think that is a huge accomplishment, and I do think that folks will see a difference. So that's the only thing I'm aware of.
Okay, so follow-on question is, to have 50 states attacking the same problem versus federal government attacking this exact same problem, is this an effort that we need to start setting up staffing at a state level if in fact the federal government or our federal representatives are doing exactly that? I don't want to duplicate efforts. Certainly don't want to duplicate efforts 50 times over. I just wonder if you can comment on that.
Sure, I'd love to. And I think that the efforts could be complementary. In my mind, I see them as very different. That they're working directly with the pharmaceutical companies to negotiate a price. We're at the state level. We're analyzing the drug costs for Vermonters and setting that upper payment limit if that's where we end up. So I think it's a yes and in my view that we need every bit of effort on every level to combat the price of drugs.
Okay, that's
Can
fair.
I, Susan, and I know Senator Hardy has a question, quick question. Historically, the Medicare negotiation, the ability for Medicare to negotiate drug prices, are you familiar with that history? And when Medicare was not allowed, when did that start? That started with Medicare. When was that? I don't
I think it
remember.
I think it just started, like, they announced the drugs in August. And I think
No,
there's
no,
a,
I'm not talking about when we were allowed to negotiate. Talking about when it was put in place that it was disallowed, there was no,
oh,
when did Medicare start? Was
I don't
that,
think, yeah, I don't think we've ever been able to negotiate drug prices, right?
it's taken what, 50 years,
Yeah.
60 years? 60 years at the federal level to begin to negotiate drugs for this huge population of folks in Medicare. All of a sudden, so Senator, I'm answering your questions.
I hear you.
Okay. 60
I'm
years is a long time. Well, I don't know. I think, our congressional delegation is powerful, but I don't know if they're gonna be able to whittle 60 years down to 6. Anyway, so we can debate that issue going forward, but, so it is important for states to send a message. And this is those states that have already started, Maine included in our area, sending a strong message about drug pricing is just out of pocket, out of hands, out of the world for our citizens. Anyway, Senator Williams, and Senator Hardy's first, sorry.
Oh, thank you, Madam Chair. I just wanted to respond to Senator Weeks, but you said some of what I was going to say. But also the federal government's authority on Medicare drug negotiations is very limited. It's, I think, 10 drugs, so that they only can do negotiations for 10 out of the hundreds, maybe thousands of drugs that people, and it's only for Medicare. And so that's also a limited part of the population. And I think the point that Susan made, that this would be specific to the affordability for Vermonters. So it would not only be the price, but it would also be the economic situation for people in our state, and sort of looking at the two together and deciding, are these drugs affordable? So I think that having both the state and federal processes is really important. I mean, to your point, I wish that at the federal level, we had a much more robust ability to do this, and that it would be nationwide, and that it wouldn't be left up to the states. But as we're seeing time and time again, our federal government is not being effective at legislating, so we have to step in and do it.
Well, but the fact that we've got Medicare is a big step, and our delegation has been important in that.
Yeah.
You're right, yeah.
Just broadly speaking,
Yeah.
I mean, look at the U.S. House of Representatives and how completely how they can't do anything. Yeah.
Are you good? That's okay. I know you're good. All right. Anything else? No, when I was mentioning the data piece, that's the piece about what are the drugs that Vermonters use and how do we slice that out of everything based on cost. So that's a big piece of it. Yeah, and you did mention that. So, all right, so can we ask for some further help from you on this issue? I'm looking at Julia because it's like you're the point person getting the data. We want to modify the language so that we can take steps forward, but I'm not sure that we're going to be able to put a full 5 FTE, all the resources needed in the beginning. So it would be more helpful to understand what progression we'd have to put in place. What do we have to have first to do X, Y, or Z, and then set a plan, a trajectory going forward. We'll have to think about, this committee will have to talk about that, but your help would be helpful, whatever you can provide.
And Senator Lyons, I think that actually is one more thing I want to say is this just setting expectations, the ramp up phase and being aware that this is not going to happen overnight, certainly need the resources, appropriate resources in an approach to get this done well, right? But the other states, I think Julia has been talking and hearing like 3 or 4 years they've been working on it, and they're starting to make progress. We can build on what they've done. They've already, we can take and borrow what they've done, but I think we have to make sure that we have time to ramp up.
Okay, I mean, that makes a lot of sense. Okay, thank you. Appreciate it a lot.
We'll see you in there next week. I'm feeling much better.
All right. So we have next up Rachel Cobble Latham, Pharmaceutical Research and Manufacturers of America. Here you are.
Hello.
Thank you for being here.
Thank you for having me.
And you don't know the committee, so we're going to introduce ourselves.
Wonderful, thank you.
Go ahead.
Hi, I'm Senator Ruth Hardy from the Addison District.
And I'm Senator Terry Williams from Rutland County.
Jenny Lyons, Chittenden Southeast District.
Good morning, Dave Weeks, Rutland County.
Martine Rockula, Chittenden Central.
Good morning, and as the chair said, I'm Rachel Cottle Latham from Pharma. And I'm just going to pass around a few slides that will help guide the presentation, not rigidly, but just as a visual anchor.
Can we get this electronically so we can post it for folks?
We can certainly follow it.
Yeah, that would be good. Thank you. I have extra sheets.
Fantastic.
Another one? And no one needs
We
one.
prepared a few additional for staff if needed.
Thanks.
You have this one? I think this is extra. I don't know. Is that extra? We're one short. Kiki maybe left David. I'll give you mine. Get it electronic. We got it electronically.
Of course.
You got everything. Yeah, you want mine? I'll borrow Kiki's. Okay, go ahead.
Sure. So as I said, I'm, for the record, Rachel Cottle Latham. I am Director of State Policy with Pharma based here in the New England region. And I also wanted to briefly introduce my colleague sitting behind me, Kelly Latham, who is also here from Pharma as a phone a friend option. So, but I am here today just to express our concerns with Senate Bill 98. So as you are aware, Pharma represents the innovative and research-driven biopharmaceutical manufacturers. And I would like to say from the outset that we absolutely agree that patients need to pay less for medicines. And this bill's approach, however, of setting price limits by way of an upper payment limit for the entire drug supply system would put patient access to medicines at risk and really have long-term harmful effects on innovation and the development of new and life-saving therapies. But at a national scale, prescription medicine costs account for approximately 14% of total healthcare spending. And that's a figure that has remained stable and is expected to remain stable for several years, even as new treatments and cures are coming to market. And the growth of net price, which reflects manufacturer rebates and discounts, has been in line with or below inflation for several years, even as new treatments and cures are coming to market. And I have a slide to that effect. It's slide 2. The growth of, Dr. Sokol raised some really important points of discussion last week about the impact of out-of-pocket costs on consumers and how to best help consumers at the pharmacy counter. And to be clear, there is nothing in this bill that directly drives at that issue. This legislation really focuses on review of prescription drug costs while ignoring the variety of stakeholders across the supply chain that determine things like drug coverage and out-of-pocket costs, and that ultimately determines what consumers pay for a medicine. Just as an example, the considerable rebates and discounts that manufacturers offer to health plans and PBMs don't make it to patients at the pharmacy counter. And these rebates and discounts totaled approximately $256 billion in 2022. So that's not a small sum of money at play in the system. And I would like to just point out that on average, more than half of all spending on brand prescription medicines goes to someone other than the manufacturer who researched and developed the medicine. So despite these rebates and discounts, when patients are facing deductibles and coinsurance, health plans are typically basing a patient's cost sharing on a medicine's list price rather than the discounted price that the health plan receives, as I think Dr. Sokol had pointed out also in her testimony. But it's important to mention this because it's unique to insurance coverage of medicines, and patients receive the benefit of negotiated discounts when sharing in costs for hospital services, for example, but not for prescription drugs. And at the same time, trends in plan design are shifting more costs to patients through high deductible health plans, through coinsurance, and that's leaving patients to really struggle to afford their out-of-pocket costs. And none of this is really addressed meaningfully in this bill. And we feel really strongly that patients should be benefiting at the pharmacy counter. Price controls, in addition, like the one in Senate Bill 98, also raise preemption concerns under the Supremacy Clause, in addition to some concerns about Vermont's ability to regulate commercial activity beyond its borders. And since prices are set nationally, it's important to point out that this bill creates a price control in Vermont across the supply chain. And there are a lot of practical questions that remain about the impact on Vermont providers and patients. Just as an example, how will a pharmacy who purchases medicines from an out-of-state wholesaler but then can't source the product for the upper payment limit be adequately reimbursed? And there are other questions as well, but history, importantly, has shown us that in other countries that have resorted to government price setting, patients have access to fewer new medicines and they wait longer to get the medicines they need. I also, just kind of getting closer to the end of my comments, do just want to touch on the conversation about patents that came up during the hearing last week. So earning a patent, it's important to point out, is a really early step in developing new medicines for patients. And once an initial patent is granted, innovators typically spend years in clinical trials proving the safety and effectiveness of their drug before it goes to market. Exclusive rights that are granted by a patent give protection to a company that's really taken all of the initial risk against having their invention copied for a period of time. But it's important to note as well that innovators must publicly share information about their and their innovations, allowing more generics to be developed. But an example of this, and there is a slide to this effect, is the case of hepatitis C. And in 2014, a new drug came to market that provided a cure for more than 90% of patients with hepatitis C. And patients with hepatitis C often needed liver transplants, which were very expensive, could cost around $500,000. But several new treatments since 2014 have come to market that have driven down the price of the medicine. And recent research indicates that these medicines have saved Medicaid around $15 billion, and that the cost of a cure is now lower than just 1 year of disease burden. So in starting to wrap up, there are policies that would protect patients where they need it most, without risking access and future innovation. And as an example, I think it was suggested by Vermont's Department of Financial Regulation in the Act 131 report issued in 2022, Vermont could consider requiring biopharmaceutical manufacturers to share rebates and discounts with patients directly at the point of sale to reduce their out-of-pocket costs, which is where we know patients are really struggling and feeling the pinch most. So we think this would provide immediate savings for patients and just be much easier to operationalize than the complex proposal outlined in Senate Bill 98. We really do want to help lower barriers to ensure that our industry's medical innovations can benefit patients. And Senate Bill 98, we feel will not achieve the desired result. So I do thank you for allowing me the opportunity to speak and be here with you today. And I'm very happy to answer questions.
Thank you. That was succinct and clear. I appreciate that very much. So I have some questions for you, and one is that have you, or obviously maybe other representatives of pharma testified in Colorado, Maine, New Hampshire, and the other states who have put in place prescription drug advisory boards?
Yes, other of my colleagues have,
Yeah.
who represent other states. I represent the New England region, but have testified in those states.
Are there any pharmaceutical companies, manufacturers that are neutral on this type of program?
I know that, so I represent the Trade Association Pharma, so I can speak on behalf of the association, but we are opposed to the concept of setting upper payment limits through prescription drug affordability boards.
So, yeah, all right. So individual pharmaceutical companies may have their own perspective on this.
Yes, I will let them speak individually
for
themselves.
Thank you. Then you mentioned the patent time. I think it's a 19-year time frame when, and then patents expire.
It's about 20 years, but 13 years on
more or
average.
less. And then the issue there, and that I've talked with lawyers who have worked in this area, is that frequently what happens is that the industry will offer a buyout to smaller pharmaceutical companies when they want to go forward with a new generic drug. And are you familiar with that at all?
You know, with respect to the patent issue, what I can say is that you cannot extend a patent on an old medication.
No, but you can produce the old medication and at a cheaper price than what the original company is producing it. And then you can, if the original company offers you a buyout on that, it might be more lucrative than trying to go through and manufacture and sell.
Yeah, I'm not sure about that specific circumstance, but I know that, you know, with respect to the patent system in general, it is true that, for example, if you had a infusion-based medication, you know, come to market, and that is a patented product for that specific indication, you know, there may be down the road a new innovation that enables that injection to be done at home. And so there can be a new patent for the new product, for example, but that former patent would not be extended beyond that original patent term.
And then the issue that we confronted several years ago around importation, and Vermont was the first state to pass that law, and then I reported on it in Florida when we had that law, and the prices are less in Canada. And so if we could import Canadian pharmaceuticals, they're less expensive. How does pharma view that?
It's a very good question. So, you know, I would point out with respect to kind of looking at prices in other countries that it's a little bit of an apples and oranges comparison because, you know, I would point out that in countries that do have price controls, patients have access to fewer medications and it takes longer for them to receive new medications. So as an example, you know, I think the United States patients have access to around 85% of globally available treatments on the market, whereas you know, patients in Europe, for patients in Europe, I think that number is around 40%, and in Canada around 45%. And then with respect to kind of the time it takes for the new innovation and treatment to reach patients, in Europe, I know on average that time frame is around 2 years longer. And 2 years, you know, it doesn't maybe on paper sounds like a very long time, but if you're a patient in Europe or a parent of a patient in Europe who's waiting for an important new treatment that's available in the United States, for example,
But the price in Canada is less, and if we can import the drugs that we can access, then the price would be less in the United States. So does pharma have a position about that?
Yes, we oppose the concept of importation. We think that it creates a great safety risk to medications entering because drugs that are entering.
Okay, thank you. I mean, we're going back to testimony that we've heard in the past, but I do appreciate understanding that pharma does have the position against importation.
Yes.
Okay. Yeah. Okay, I don't know.
Yeah, that's okay.
Yeah. We have questions from the committee. Good. Go ahead.
Do I? Okay. You know, on your last slide, you list some things that you think will help save patients money. And you list the coupon count, make coupons count. And it doesn't ever make sense to me that the pharmaceutical industry, the way that they try to, you know, claim they're making drugs cheaper for people is by offering coupons and rebates and these complex things to help, that they think will help patients pay less for pharmaceuticals. But it makes it more complicated for people to figure out how to access those coupons and those rebates. They often don't get those coupons and those rebates. And why don't you just make the price of drugs lower instead of making a complicated system that nobody can navigate or access, especially people who are dealing with health conditions that are life-threatening to them. Just make the cost lower instead of making it more complicated with coupons and rebates.
I take your point. It is a complex system, and we would absolutely agree with that. And I think that, you know, if we were a unilateral actor in the system, we could have a single-handed influence, for example. But there are other actors in a very complex supply chain as well, and there are factors to be considered as well, such as plan design, for example. With respect to coupons specifically, you know, because patients are increasingly facing higher cost sharing, they're having difficulty affording their medications, or having to make really difficult choices when they get to the pharmacy counter about whether they can pick up their medication, adhere to their medication, if they need to ration their medication, contributing to larger costs overall. And manufacturer coupons, we would like to see them provided directly to patients so that patients can use them to lower their out-of-pocket costs without that being counted against them. And
just lower the price, then you don't need a coupon. Just make it cheaper for people to access the medications. Your industry's profits are enormous, enormous. And you're saying we should just have coupons?
No, that's not what I'm saying. You know, what I'm saying is manufacturers are rebating significant amounts of money back to the system. So I would point to the net price of medicines, which has, I will reiterate again, been at or below inflation for the past 6 years. And I think that actually the slide that I provided to you might be recently a little out of date. And the more recent number is that net price of medicines has actually decreased by around 3%. So, you know, that net number, which reflects the true cost of the system, has been pretty stable.
Senator Goulart.
We want to reduce barriers for folks, and coupons and rebates are barriers. So I just want to echo what my colleague is saying. We want to get people healthy in the simplest way possible. And those two things are barriers, period.
I hear your point, and I agree. You know, we really are here at the table because we want to be part of the solution. And, you know, I think, you know, if we can offer solutions, one would be sharing manufacturer rebates with patients directly at the point of sale to lower that out-of-pocket cost.
So your suggestion is well taken, and I've written a note down myself to go back and look at the report and see if there's something we can add into the bill or not. It may be handled over in the other, in the House, but your position in representing pharma is a difficult one. We understand that. We also understand that a significant amount of our prescription drugs are produced in China. You know, it's up to 85%, I think, and that's a less expensive market over there. So we're interested in making sure that Vermonters can go into a drugstore or their clinic and have access to the drugs they need at a price they can afford. And I think that's what you're hearing. So I really appreciate your taking the time to be here, and your colleague as well. Well, any other questions, Senator Williams or Senator Weeks? What work are you doing at the federal level to help reduce costs?
We are really focused on the influence right now that some other actors in the system are having on prescription drugs. For example, there are a lot of misaligned incentives in the system that we feel are really driving up prices, including list prices of medication. So around 3 of the largest PBMs control around 80% of the market, and PBMs, if you're familiar with them, control the formulary. And currently the way PBMs are compensated, they are compensated based on a percentage of the list price of a medication. And
So are you working against PBMs at the federal level, or?
so we're working to try to correct some of the misaligned incentives that we feel are in the system, and we think PBMs are part of that system. And so we would like to see the link broken between the list price of a medicine and PBM compensation. Not saying that PBMs shouldn't be compensated for the value of their work, they should be. We think it should be fee-based though, and not tied to list price, because it's potentially keeping prices elevated.
Thank you. It's a big deal.
Indeed.
Keep up the good work at the federal level and help us understand how we can lower prescription drug costs here in this state. And then as you're looking at other states and the work that they're doing, there needs to be a collaborative process ultimately with manufacturers. And you represent that trade industry.
Yes, and I would love to continue the conversation. Please, I'm based right here in New England, so feel free to reach out to me anytime that I can be helpful as a part of that conversation.
Thank you very much. Appreciate your time.
Thank you, it's been a pleasure.
Great. Okay, so we're going to move on to, is Jeff, okay, Jeff Hochberg is here.
Madam Chair, we're gonna do a tag
Are you
team
gonna be
if that's
together?
okay.
Terrific,
He's gonna
okay.
lead, I might do a
And
little
Theo,
wrap-up.
you're here as well, so both of you together, I'll let you guys introduce yourselves, and then, yes, we're gonna get digital copies of your testimony and your slideshow. Thanks.
Greetings, can everybody hear me okay?
Yes, you're fine.
Excellent, thank you. Well, thank you, Madam Chair, and thank you committee members for having us here today. My name is Jeff Hochberg. I am the Executive Director of the Rutland Pharmacy Group. We have 6 pharmacies in Southern Vermont. We are 6 of the 16 independent-owned pharmacies in the state that are left. I think many of you know I've been an advocate for pharmacy transparency and reforming the system to a much greater extent for a long time now. And I'll come right out of the gate and say we are very supportive of S98. I think I've shared this with many of you already, how excited we were to hear that we're going to finally take up prescription drugs, how they impact healthcare, both at a premium level and an access to care level and an outcomes level. It's way overdue. And I think I've enjoyed the conversations here today because I think it really paints that picture. It's been a long time in the making. Pharmacy sits in this, outside of healthcare realm. The pharmacist not a truly recognized healthcare provider. And it's been largely dominated by commercial, market pressures, inflationary pressures, certainly. And we've seen a lot of misdealings happening. I think that's coming to light, and a lot of the focus has really shifted to how can we fix this. And we greatly appreciate S98 and want to work with the Green Mountain Care Board. I do think that, just to paint the picture a little bit, Madam Chair, from what you started with, it has been a long time. I grew up in this industry. My parents started our family pharmacies back in 1982. Back then, pharmacies bought directly from the manufacturers. Your typical volume-based rebates were there, but nothing to any large extent that was outside of any market acceptability. But in the 90s, when the Medicaid rebate exclusion kicked into gear, it kind of opened Pandora's box. And since that time, I have seen the degradation of our system play out because of a lot of back-end scheming, confusion as to what the price is, flat out obscuring real costs, real prices, to where we don't know, right? Step number one, and I think Ms. Barrett said it quite well is we need to understand the data. You know, Vermont is way ahead of everybody because of the work your committee and the other committees done on passing Act 131 of last year, allowing pharmacies to disclose all of the information that we hold, the claims data, the contracting data, everything that's there. It's a lot. It's very impactful. And certainly to rates, and as an employer, I know directly how it impacts my premiums on an annual basis. So we need to look at it. We need to unpeel it, but the Green Mountain Care Board does need to build the resources to better understand that data. As they mentioned, the VCures data does not get data from pharmacies. There are data miners out there. There are companies that extrapolate data. Your pharmacy data is typically sold in de-identified formulations to national companies that use it for all sorts of reasons. So it's something that we could turn a switch on today, and the Green Mountain Care Board would be absolutely flooded with a massive data set, and quite frankly, wouldn't know what to do with it. You have to understand there are a lot of moving pieces to it, and we do need to be very careful in how we go forward, because we're sitting at a point in time where pharmacy is on a precipice. There's a lot of people calling it the DIR Armageddon, DIR hangover. It is the worst financial period of time for sustainability efforts for pharmacies. We will see more closures nationally. We'll see more closures here in the state of Vermont. And it's crucially important that we maintain access to care. It goes, you know, just to kind of paint the picture of what the data kind of really shows is, you know, we don't understand, we want to try to tackle prescription drugs from a insurance, you know, upper limit level. That doesn't tackle the acquisition cost from the wholesalers that the pharmacies get. We do appreciate the recognition and support for pharmacies by maintaining our reimbursement levels, but it doesn't necessarily protect margins and operating functionality because of it, the way it's structured in the current in S98. Not to say that it's not a good tool, and should the Green Mountain Care Board create a board that oversees this, they certainly should have the authority and the power to execute upper limits if they are appropriate. But that does require great consideration to the impact of not only pharmacies, wholesalers, but also hospitals. A lot is back end tied to the 340B program, which is, I won't even go into because I'll just make everybody's head spin. But that has everything to do with coupons and rebates and acquisition costs and list prices. You heard from Pharma about how the list price is greatly affected by the fees paid to PBMs. On average, I think there's a report that comes out annually by a drug manufacturer called Janssen, and they do the Janssen Transparency Report, and it shows that the average list price of the drug at which the wholesalers purchase from the manufacturers, is 50% of that list price is a fee paid to the PBM to put the drug on the formulary. Okay, so, you know, that's why there's coupons, because manufacturers need two things. They need the data to continually evaluate the efficacy of the drugs in the marketplace, and they need formulary placement, because what the patients experience is entirely dictated by the insurance plans. 97% of my business is insurance, and everybody has out-of-pocket limits for prescription drugs, and then we bury the rest of it in premiums and rate filings. So we need to uncover that. We need to peel back the onion, strip it down to all of its essential parts. We need to do so across markets, from the fully insured book and the self-insured book. And we need to better understand, what any changes we do, how they're going to impact. There's a lot that's coming. There's a lot that's changing. It's going to be changing very quickly. I was on the National Association of Community Pharmacies team to work with CMS on the maximum fair price. It's concern. There's a lot of concern about how it's going to be implemented, and there's still a lot of uncertainty as to who is actually going to be administering the program. So it's important that we, I think, as Vermont, and going back to something that Senator Weeks suggested, we as Vermont do need to prepare. We need to be ready to take care of Vermonters. We need to be ready to adapt quickly to an ever-changing landscape and respond with real-time data and solutions. What I would suggest is actually going into something with maybe a potential pilot. My pharmacy, our pharmacies, we dispense roughly 400,000 prescriptions a year in the state of Vermont. I can turn that data over to the Green Mountain Care Board, give them a sample. We could learn how the ERISA book is being impacted, how the commercial book is being impacted. We can really dive into the details and the granularity of certain medications, high cost versus generic.
So Jeff,
Yes.
Jeff, thank you. We've got some testimony here from you, a slideshow, and then we also have a report that you've issued. And I'm very cognizant of the time that we have because we want to take a break before we move on. So if you have this testimony in writing, it would be helpful for you to send it in. And then, and take us forward here because I know that Theo is waiting also to testify. So help us follow along where you are.
Okay. Yeah, I'm really not sticking to, I think the slide deck that I sent you was something I've done in years past. I'm really highlighting what we're talking about, list price versus retail price versus premium, how that all impacts. And I think that that should boil it down for you to all the different inflationary points that are in this market that I think we need to address, that the Green Mountain Care Board through this board would need to uncover. We need to look to somebody to help us understand that. I point to 3 Axis advisors, the 46 Brooklyn crew, who've done a lot of work for state regulators and other states in really working on their Medicaid programs. And going to what we do here in Medicaid of a fee-for-service model. We've done the right thing for a long time. We've been leaders. But we need to now take it to the next level. And we don't need to get into the slides. I think I really want to turn over to questions and let Theo kind of give a presentation. But if there's anything else I can add to it, I'll certainly follow up with more testimony in writing for you.
Okay, good. Thank you. It's good. Great. Theo, I guess you're up.
Well, good morning, and thank you, Madam Chair and members of the committee. My name is Theo Kennedy. I'm an attorney in private practice. I'm also a public policy attorney, aka lobbyist. This work is very near and dear to my heart and mind. I was a former director of health rates and forms for the state over in what's now the Department of Financial Regulation. I was director of planning, policy, and regulation at the Agency of Human Services when Medicaid eligibility and covered services were together. And I had the pleasure, along with many other of my compatriots while still in government, to help implement the outpatient prescription drug benefit under Medicare Part D. Just for a quick point of reference, that highly contentious provision about not being able to negotiate with manufacturers was one of the linchpins that kind of brought the Medicare Modernization Act of 2003, which created the outpatient prescription drug benefit under Medicare Part D, kind of across the finish line. Like many huge areas of legislation, there's often compromise, and there are a lot of other pieces in Part D that reflect that compromise. So I want to speak to S98, and what I did is, because there are two kind of cliche things that I like to say, and I'll borrow this from another community. You know, nothing about us without us, right? I represent the independent pharmacies and other retail pharmacies. I represent the Vermont Pharmacists Association. Different retail pharmacies are in different positions and different pharmacists are in different positions, but they are very grateful that the attention to this is being put forward, particularly in S98. So I prepared 2 paragraphs, and then I have a couple observations about the bill in specific areas where you might consider tweaking, perhaps consistent with our testimony. Just to kind of go back to my one of my 2 bosses here today, because I'm here as a lobbyist. Jeff is an expert. He has put his career really on the line to try to help Vermont pharmacy and consumers. So it's not just on behalf of his pharmacy or on behalf of his own benefit that he puts forward both the positions I'm going to talk about, but also the work that he's been doing in the building over the last decade. So briefly, because it's easier for me to do so, I sent this to Kiki, it's online, I don't have a hard copy, but I'll just read, which is not my typical style, but I think I want to get these 2 paragraphs out there, and then again, turn to the bill briefly, and I thank you. So, the Rutland Pharmacy, I'm starting to read, the Rutland Pharmacy and the Vermont Pharmacists Association generally support and applaud this bill's purpose to give the Green Mountain Care Board, GMCB, the statutory authority to comprehensively evaluate the cost of prescription drugs in Vermont. The political autonomy and expertise of the Green Mountain Care Board is a good fit for this undertaking. And in terms of statutory role clarity, to kind of harken back to some of the testimony we heard in S211, Rutland Pharmacy and the Vermont Pharmacists Association hold this step as welcome and in fact long overdue. As for years, there has been a lack of clarity as to which party in government was squarely in charge of working to make prescription drugs more affordable in Vermont. And as an attorney for 30 years, not quite that many in Vermont, that's really important. You know, where do we go in our green books? I brought one of them today for a certain point. Where do we go to get our questions answered? Of course, we go to different parts of ourselves, whether it's AHS or the Office of Responsibility or to the Green Mountain Care Board or to the Department of Financial Regulation. But this would squarely give a charge to Green Mountain Care Board. Rutland Pharmacy and Vermont Pharmacists Association, with new data sharing protections recently passed into law by the Vermont legislature, which we thank you for. That was in Act 31. It's very, very significant. Limited gag clauses and other types of things. I mean, this is a little colloquial. It would kind of blow on away if you knew that my boss could go online and look at what each drug was paid for, what each payer reimbursed for it, each and every day, for each and every prescription, 365 days a year across all payors. That's information that we've never had available to us. And working with that data, I think, is the key to making informed decisions. Let me just make sure I wrote this up and I don't want to take too much of your time. So I'm just going to repeat that sentence. Rutland Pharmacy and Vermont Pharmacists Association, with new data sharing protections recently passed into law by the Vermont legislature, and their financial and clinical provider expertise and experience, look forward to helping the Green Mountain Care Board and the Prescription Drug Affordability Stakeholder Advisory Council in any way they can to reduce prescription drug costs and associated pricing processes. And I'm going to come back to that, and I'm trying to be brief, and to improve access to high quality care for all Vermonters. That's paragraph 1. Paragraph 2, and this is more focused on the bill now itself. More specifically, we think that the scope of the bill need not necessarily be limited to high-cost prescription drug products, as the reasons for high cost is embedded in the current delivery system that perpetuates them. Without analytically getting at the root causes, as we all watch premiums continue to go up year after year, while community pharmacies close and access to quality clinical pharmacy care is reduced. We hope that the Green Mountain Care Board be given the resources and authorized to do the analytical work first, and then make, quote, any recommendations for further legislative action needed to make prescription drug products more affordable in the state. And that's, I think, the last sentence of this bill in section 9375B16B3. Before any upper payment limits or other fixed pricing or reimbursement methodologies are instituted that unintentionally and potentially further exacerbates, I think I might have a subject pronoun and verb, lack of correspondence there. A stress pharmaceutical, potentially unintended consequences that further exacerbates a stress pharmaceutical, financial, and clinical delivery system in Vermont. You know, there's no question that pharmacists are part of a quality healthcare team. We are very grateful in this bill, to quickly run down to the bill, that you've used the definition of healthcare provider that actually lists pharmacists. They're often not listed, and in this area it would be, it's not a legal term, kind of absurd not to list them, since this is at the heart of what they do. In a way, they're two fixed pieces of a very complicated puzzle. We never build a hodgepodge house like this if we started from scratch, right? You have your pharmacists, and your manufacturers, or maybe I should do it the other way. You have your manufacturers and your pharmacists, and then there's a lot happening in between. Whether it's PBM practices, pharmacy services administration organizations, wholesalers, group purchasing organizations. I think testimony from Farmer, I think, lands that part of the discussion very, very well. There are other places to look to understand where there can be cost savings, and without the data to understand that, you're not, with humility and respect for everyone in the system, you're not really able to make informed decisions without all the information. And pharmacy is an outlier in this regard. We have cost utilization, admin, risk data at a very granular level as part of actuarial and other analyses that attend to rate making and hospital budgeting. In the pharmacy space, a lot of that is obfuscated. And I think we are at the cusp of a really great opportunity for Vermont to continue to lead. In the bill itself, so again, we generally support, we don't think the price fixing piece is necessarily the remedy, nor necessarily to all parties' advantages out of the gate. Looking at the bill itself, just quickly, there are a couple areas where there's language about scope. I'm talking initially scope of review, which is, I'm just trying to get the section numbers, that's 4672. And then in D later on, where we think if you added to the scope, not just prescription drug products, but something I talked about, or other drug product pricing methodologies or processes. So I think if you want to give the Green Mountain Care Board, I hope, the latitude to look at the landscape and understand where are the cost pressures and why do these coupons creep up and why aren't these rebates passed on to the consumer, and hear better from Medicaid, for example, as to why do they have no spread pricing and why do they have a pharmacy benefit administrator rather than a PBM. So yes, the couple places where you're talking about the scope as being limited to drug product, we would like to think that their charge could also include, again, looking at other pricing impacts within the system, that rather than just the price, which seems high now, but really is the result of a system that all the factors are not really fully understood yet. And then just briefly in closing, thank you so much for recognizing independent pharmacies on page 9 of the bill. There's kind of a hook that you have back to the maximum fair price stuff with the Medicare. I think that's very important. We just hope that whatever pharmacists and pharmacies get reimbursed is tied to something real, like an actual acquisition cost, plus, instead of dispensing fee, we're trying to start saying professional fee. You've worked with us to expand the scope of clinical pharmacy. You've given pharmacists new opportunities to enter and kind of live through their key role and desire as pharmacists, which is to be part of a clinical healthcare team. This is a place without, I'm going to wind this down, pharmacies buy these drugs, right? And then they're subject to the reimbursements of any number of payers. Ideally, we'd like to see pharmacists excise from that part of the equation and really be able to focus on clinical care. And then there's one little piece, and so just a lawyer in me that spins around words. On page 7, there's a language that says, and I just throw this out for not inquiry today perhaps, but for Ledge Council, because some of this was modeled on laws from other states. It says, quote, the upper payment limit established by the board for prescription products shall apply to all purchases of and payer reimbursements. So that just, when I think about it, that blends two things that are very, very different. And if the purchasers are going to be subject to a limit and the reimbursement, then there's other language just from the preceding page where you also
Theo,
decouple,
can you do me a favor?
write those down and send them to you?
Write it down and
Yeah,
send it in,
okay.
because we're not ready to do the markup yet,
Right.
but we do
Right.
understand that you have some
Right,
concerns about language, so
yeah,
just do that,
yes,
because we're at a stage where we need to take a break,
yeah.
and,
Well, and I
so-
thank you so much
yeah, no,
for
thank
being,
you.
being
The
able to
work
talk to
that
me.
you do consistently, you and Jeff, and helping us understand the issues is very important, and we very much appreciate it.
Well, we'd love to have you have us back, so we're not gonna stretch our welcome today. And we thank you very
Well,
much for
we'll
the
have a lot of people
opportunity.
back. I imagine that this room will continue to be full when this bill is taken up, so.
But so in sum, we generally support it. We think the Green Mountain Care Board is the proper entity, and we're not yet sure about this.
So send us your full testimony that
Mhm.
you had. I know you didn't mention Act 31 in the
131.
paragraphs that you read, 131. And then also the
Specifics.
highlighting the places of your language,
Mhm.
areas of concern, that would be helpful. And so